We see what are the algorithms for classification of anemia. If you get a patient of anemia, how can we classify? There are multiple systems of classification for locating the cause of anemia. So first we see the use of the reticulocyte counts. If you find anemia, go for complete blood count and reticulocyte count. We actually do not see absolute reticulocyte count. We calculate the reticulocyte index, which can be calculated from formulas given online. You put in certain values and you get those reticulocyte index. If a patient has reticulocyte index of more than 2.5, this is possibly hemorrhage or hemolysis. It may be hemolysis or hemorrhage. For example, patient may have blood loss from the GI tract or from the gynecological tract, sometimes from the urinary tract, or the patient may have intravascular hemolysis. For example, there are metabolic defects which can cause like glucose 6 phosphate dehydrogenase deficiency, membrane defects like hereditary spherocytosis and elliptocytosis. Then you've got hemoglobinopathies like thalassemias or sickle cell disease or the other hemoglobinopathies which are uncommon. Then you've got immune destruction. Immune destruction can be caused by autoimmune hemolytic anemias, and then a patient may have fragmentation hemolysis. Fragmentation hemolysis is seen, for example, in patients who've got prosthetic heart valves, particularly the metallic type of prosthetic heart valves. Sometimes this may also be seen in condition like DIC. Then you got patients who got anemia with low reticulocyte index. Now in those patients, we go for the RBC morphology. What are the RBCs like? So if you got microcytes or macrocytes, this is usually a maturation defect. And you see if the maturation defect is in the nucleus, it is usually because of folic acid deficiency or B12 deficiency. There may be drugs which may be causing it, or there may be a condition called resistant anemia. And if the defect is in the cytoplasm, it may be iron deficiency anemia, this may be thalassemia, or this may be sideroblastic anemia. And then you see if the RBC morphology is normal, they are normocytic, normochromic, this is possibly a hypoplastic state. It may be because of bone marrow damage, for example, in bone marrow infiltration by malignancy or tuberculosis or granulomatous tissue or myeloma cells, or patient may have fibrosis, or they may be aplastic anemia. Then patient may have iron deficiency anemia. They may present like this, and patients sometimes they present those patients which have decreased stimulation. For example, if there is erythropoietin deficiency, as is seen in renal failure, patient may be they are hypothyroids, and patient may have underlying inflammatory disorders which suppress the bone marrow. So the patient may have anemia because of these conditions. Now there is another way of classifying anemia, that is on RBC size and red cell distribution width. Now we see how we can classify anemias with cell size and red cell distribution width. First we see patients who've got low MCV anemias. If they have normal red cell distribution width, this means the patient may have thalassemia minor, they may be anemia of chronic disease, patient may have certain hemoglobinopathy traits. And in patients who got microcytes with high red cell distribution width, there may be iron deficiency anemia, there may be hemoglobin H disease, the patient may have anemia of chronic disease, there may be some thalassemia minor patients, and patients who got fragmentation hemolysis, so red cell distribution may be high. And then in patients who've got normocytic anemia, the RBCs of normal size, you may have anemia of chronic disease if the red cell distribution width is normal. They may have spherocytosis, there may be acute bleeding, and some hemoglobinopathy traits. They can present with normal red cell distribution width. And then patients who got normocytes with high red cell distribution width, this could be because of earlier partially treated iron deficiency anemia, or there may be other vitamin deficiency anemias like B12 or folic acid deficiency anemia, or the patient may have sickle cell disease. Now, if you see patients have large cells, macrocytes, more than 100 MCV. If they have normal red cell distribution width, this can be because of aplastic anemia, and this can be because of myelodysplastic syndrome. And patients who got macrocytes with high red cell distribution width, this can be B12 or folic acid deficiency anemia, autoimmune hemolytic anemia, this may be cold agglutinin disease, patient may have myelodysplastic syndrome, there may be liver disease, patient may have hypothyroidism, and patient may have chronic alcohol use that is causing large cell anemia. And then we can go another way. We go for a smear review and we see what is the abnormal morphology that can help us. For example, if there is sickling or their target cell, it is hemoglobin S disease, hemoglobin SS disease, or it can be thalassemia. If the patient has target cells and stippling, this may be because of thalassemia minor. And if the patient has many target cells, this may be because of hemoglobin E disease, hemoglobin C disease. It may be because of chronic obstructive liver disease, for example, primary biliary cholangitis, that may produce a large number of target cells. Patients who've got RBC fragments, they may be because of hemolysis. Similarly, patients who've got Rouleau formation, that may be because of increased immunoglobulins or decreased albumin. And then when the smear is non-diagnostic, we go for the red cell distribution width. And you see if the red cell distribution is more than 16, the possibility is that this is iron deficiency anemia. When we see iron deficiency anemia, we go for checking the ferritin. If the ferritin is low, this is iron deficiency anemia. Virtually, this is iron deficiency anemia. And you see rarely when there is congenital ferritin deficiency, this may not truly reflect, but that is very uncommon case. And if the ferritin is non-diagnostic, we go for transferrin saturation. Transferrin saturation can be calculated from iron and total iron binding capacity, that is TIBC. If the transferrin saturation is low, this is iron deficiency anemia. If the transferrin saturation is high, more than 40, this is not iron deficiency anemia. We have to go to bone marrow. We may find patient has sideroblastic anemia, or there may be marrow failure anemia. And then smear review, if it is non-diagnostic, again we see the red cell distribution width. If this red cell distribution width is normal, what is possible? We go for the RBC count. If the RBC count is low, then we see this is possibly anemia of chronic disease. And for anemia of chronic disease, we go for tests which are dictated by the clinical condition. For example, if there's an inflammatory disorder, investigate like rheumatoid arthritis or other connective tissue disorders. Look for the presence of uremia or look for the presence of thyroid disorders. And if the RBC count is normal or this is high, this is early iron deficiency anemia, some of the thalassemia, and some of the abnormal hemoglobin patients may have this sort of picture. And if we rule out iron deficiency anemia, we go for hemoglobin electrophoresis and look for the presence of hemoglobin A2. If the hemoglobin A2 is more than 4%, this is thalassemia minor, that is beta thalassemia minor. If it is less than 4, then we go for a detailed examination for presence of other type of hemoglobins. And then next, if we get macrocytic anemia, this can again be worked up based on the reticulocyte counts. If there is macrocytic anemia, we go for the reticulocyte count. If the reticulocyte count is increased, this may be because of hemolysis, this may be because of hemorrhage, this may be because of treated B12 or folic acid deficiency. Because when you treat folic acid with B12 deficiency, the new RBC, they start coming up and a lot of reticulocytes are spilled in the circulation and some of the big cells are also present. So we can go for this and we can see this could be treated B12 or folic acid deficiency if the reticulocyte count is high. Then if the reticulocyte count is normal or it is decreased, we see the presence of round macrocytes or hypersegmentation. The RBCs are round or oval and the WBCs are hypersegmented or not. You see, we can go for a bone marrow examination. If the bone marrow examination shows megaloblastic change, this is a B12 or folic acid deficiency anemia. If the bone marrow shows non-megaloblastic change, this is because of multiple problems. This may be alcohol, this may be drug, this may be chronic liver disease, maybe thyroid disease, this may be aplastic anemia, this may be because of myelodysplastic syndrome. So you can have these different types of anemia. If the patient has macrocytes, reticulocyte counts are low, and the bone marrow shows non-megaloblastic change. So this is how we can see a patient who comes with anemia and classify in different systems based on reticulocytes or the cell size and red cell distribution width, or the patient's peripheral film and the red cell distribution width. In patients who've got larger cells, we can go for the bone marrow examination, and if there is a megaloblastic change, this is B12 deficiency anemia. If this is no megaloblastic change, the patient has multiple reasons for having this sort of problem, and then we can go for further refined testing as may be dictated by the clinical condition. So this is how we can classify patients who've got anemia.